Good afternoon. My name is Julie Postma. I'm a professor at the Washington State University College of Nursing. Welcome to Module 4, Physiological Measurement, Repeated Measures with Spirometry. In this talk, I will identify how spirometry measures were used in a translational research study. The study is titled Promoting Risk Reduction Among Young Adults with Asthma During Wildfire Smoke Events, and this was funded by the National Institute for Nursing Research. Although fire has been a natural part of Western landscapes, global warming has changed some of the underlying variables that make wildfires more or less likely to occur every year. The Union of Concerned Scientists help us visualize the connection between climate change and wildfires through this image. Higher temperatures increase the likelihood that fires will burn more intensely. Higher temperatures also cause snow to melt sooner and lead to drier soils, forests, and plants, which act as kindling. Increased droughts and insect outbreaks lead to large stands of dead trees, and that makes wildfires even more likely. Annually, wildfires are starting earlier and lasting longer, extending the wildfire smoke season. And they are expected to increase in prevalence and severity in years to come. Wildfire smoke travels long distances and affects many more people than those endangered by the fire itself. I situate my work within the National Institutes of Health Climate Change and Health Initiative, specifically around interventions and strategies. The initiative is a cross-cutting NIH effort to reduce health threats from climate change across the lifespan and build resilience and adaptation among those at highest risk. Individuals with asthma are among the most vulnerable to health effects from wildfire smoke exposure. The number of people exposed to unhealthy levels of particles from wildfire smoke increased 27-fold in the past 10 decades. In terms of the National Institute of Nursing Research and their research framework, I situate this work in homes and community settings with a focus on prevention, preventing visits to the emergency room or urgent care for asthma exacerbations during wildfire smoke season. Robust epidemiological evidence links short-term exposures to fine particulate matter, or PM2.5, the main pollutant of concern in wildfire smoke, and respiratory outcomes. Wildfire smoke exposure is associated with increased emergency room visits and hospitalizations for asthma exacerbations, outcomes consistent with exposure to ambient air pollution. So the purpose of my study was to assess the feasibility of risk reduction interventions among young adults with asthma and pilot test the interventions compared to a control group. The first aim was to establish the feasibility, acceptability, and barriers and facilitators of adopting the technology of the intervention, so these were smartphone applications, and use of portable spirometry in young adults with asthma. The second aim was to explore the preliminary impact of the interventions on health outcomes. This was a 3-arm randomized clinical trial to pilot test 2 interventions, one called SmokeSense and another called SmokeSense Plus. And again, these were 2 smartphone applications, and they had different features that I'll review in just a minute. And these intervention groups were compared to a control group among young adults with asthma. We recruited through the Western states, largely via student affairs offices, as well as via social media and professional organizations such as the Alliance of Nurses for a Healthy Environment. The study period was 8 weeks, and measures were assessed at baseline, 2 weeks, 4 weeks, and 8 weeks. Enrolled participants received a spirometer via the mail and a 45-minute video conference orientation with the research coordinator. We kicked this off during the COVID pandemic, so all study procedures transitioned to be via distance, all remote. So with that 45-minute video conference, we trained people on using a portable handheld spirometer. Participants were briefed on the study schedule and how to receive emails and study materials via RedCap. And participants in both intervention arms received an overview of the app features and were instructed to use them weekly. This was IRB approved. Our outcomes were selected to measure multiple domains of asthma, including symptoms, activity limitations, and airway monitoring. We used the forced expiratory volume in 1 second as our measure of airway narrowing, as it is not affected by failure to reach maximal exhalation. So this is really important in a community-based clinical trial versus if participants were coming into an asthma clinic, for example, where they would receive coaching and monitoring in order to exhale fully. People were doing this on their own. They did have access to a research coordinator and a video showing proper technique, but at the same time, use of the FEV1 was judicious in terms of their ability to exhale fully without coaching. We also measured the asthma control test. And that's a 5-item scale, self-reported using a 4-week recall. And that measures shortness of breath, asthma symptoms, use of rescue medications, daily functioning, and an overall assessment of asthma control. Again, we had 2 intervention groups. One used a smartphone app in existence called SmokeSense, and this was an app that the EPA developed. The second group used SmokeSense Plus, so that included the SmokeSense functionality as well as additional features which we designed for the user with asthma. So let's take a look at a few of these features. Participants in both intervention groups could access SmokeSense. So some of the tabs you can see here include symptom and smoke observations, where participants were asked to report their weekly observations of smoke, any symptoms they were feeling, and any behaviors they took to reduce their risk, such as putting on a mask, avoiding jogging outside, or taking a bike ride when it was smoky, changing air filters in their car and in their home, things of that sort. In the second tab, called Fire and Smoke Near Me, participants received current air quality notifications and the next day forecast. And these bottom 2, including Smoke Smarts and Air Quality 101, were modules that tested knowledge of air quality facts. Then our SmokeSense Plus group had some additional features to maximize risk reduction among users with asthma. So participants used a spirometer twice daily, once in the morning and once in the evening, to monitor their airway narrowing. They also used this Map It feature by sharing their color-coded spirometry reading with other participants on this regional map. So that was to encourage both peer support and awareness of how poor air quality can impact airway narrowing. They were also asked to review weekly preventive tips and post a response to the tips into the app's shared message board. So those are the main features of our smartphone applications, again, including SmokeSense, developed by the EPA, and SmokeSense Plus, our enhanced intervention for people with asthma. Well, how did we do in terms of recruitment and attrition? We had 81 participants assessed for eligibility in the summer of 2021. The percentage of eligible participants who enrolled surpassed our goal. So we ended up enrolling 67 people. Our goal was 60. Attrition was minimal. 96% of our participants completed the week 8 data collection visit. So we were pretty pleased about that. So who did we recruit? Who did we enroll? Most participants identified as female, non-Hispanic, and white. About half had a college education. At baseline, the average asthma control test score was 20.4, so most people had well-controlled asthma, and the mean percent predicted FEV1, forced expiratory volume, in 1 second was 93.1%. Notably, however, over half of participants reported being prescribed an asthma maintenance medication, yet half reported less than prescribed usage. So there was some room for improvement in this area. In terms of exposure to poor air quality, during the smoke season when our participants were enrolled. You can see in the second box and whisker plot in orange, I circled it, that 8.5% of days during the participants' exposure period exceeded the acceptable level for PM 2.5 under federal daily standards. So this level is described as unhealthy for sensitive groups or worse, according to the Air Quality Index for PM 2.5. And notably, over 1/3 of participants' exposure periods were deemed moderate air quality, which is indicated in yellow to the left. So results in terms of AIM-1, where we had questions about usage and acceptability. We had no adverse events reported, so that of course is very good. Our system usability scores indicated a stable and usable system that is in regard to both the stability of the smartphone applications and being able to access the different features, as well as using these portable spirometers. The research attitude scale indicated that 88% of participants agreed or strongly agreed that their personal information will be kept private and confidential. And that was a particular concern because we were sharing their FEV1s in that Map It feature. But young adults in this generation, in this era, are pretty okay with sharing information. Of course, that was de-identified, but we did want to make sure that that was the case. Most SSU Plus intervention participants agreed that daily spirometry readings helped them manage their asthma. And so we did a survey and follow-up interviews with people in the SmokeSense Plus intervention group, and that's what we found. We found a lot of enthusiasm around daily use of the spirometer. This quote exemplifies that perspective, where one person said, "The application allowed me to understand when I was experiencing symptoms I may not have been conscious of and to take action to manage them." So we're very encouraged by that. In terms of using the spirometer, young adults in our sample were highly compliant with regular self-administered spirometry. Over 2/3 also used the optional note feature, some of whom tracked their own assessment and self-management. For example, a participant noted that on that particular day that it was very smoky, low visibility, wearing a particle mask because I have to work today, used the emergency inhaler in preparation for today. So this just gives us insight into how we can amplify this intervention, and we learned a lot from the young adults around their use of the spirometer and the value that they found that in terms of their asthma management. So at baseline, 100% of participants were completing their scheduled spirometry readings. By week 8, it dropped off a little bit, but higher than a lot of the findings in related literature. The SmokeSense Plus group, again, was asked to do daily readings, and they completed those over 80% of the time. So we were, again, very encouraged by this. This figure shows the FEV1 measures over time broken down by study arm, so you can see how we displayed repeated measures by group. There were no group differences in primary outcomes, but examination of changes in asthma outcomes was limited by the design and purpose of this feasibility study. In other words, it wasn't necessarily powered to detect profound changes, and as I mentioned before, at baseline we had participants with well-controlled asthma, so there wasn't a lot of room to move there. Here we see the asthma control test by group and over time. Again, we saw no statistically significant group differences by study arm. Some important discussion points. Participants' asthma was well controlled at baseline. This was likely because we recruited via the community versus clinic-based recruitment. Initially, our plan was to recruit via asthma clinics. However, COVID hit and those clinics were focused on other activities. So We were lucky to have such positive recruitment and support by the student affairs offices and our various other recruitment methods. But we did see not a lot of room to improve among the participants in our study with our asthma outcomes. And we learned, again, a lot from participants about their use of spirometry, the value that they found in spirometry, and what else they needed to make that valuable in terms of their asthma self-management. So one person said, I always felt like I could never understand the stats I was getting from the spirometer. And I would have loved a, like, here's what the FEV means integrated into the app. So those were thoughtful considerations, insightful considerations, and we will build that into future testing of this app. Limitations. There was no in-person coaching for spirometry. And so as you learn about spirometry, you'll know that the literature notes that the best values are obtained with coaching. A lot of times nurses in those clinics are the ones doing that coaching. We did not have that benefit during COVID during this clinical trial, although it did allow us to test certain aspects of community-based spirometry. Our research coordinator was extraordinarily available to provide tips and support to participants. We also recorded a video of proper technique that they could refer to at any time. But it is different than in-person coaching. And we could not guarantee consistency in the approach. For example, you want standardization with spirometry. You want people to be sitting every time they use the spirometer or standing every time they use the spirometer, but we did not have that control over the environment. We have two related publications. These have been published. The first is our results paper. This was published in Public Health Nursing in 2022. And our second paper, really focused on the spirometry, is published in the Journal of Asthma, and that was published in 2023. And we have another paper in review, but we'll see how that turns out.